Hi, everyone. My name is Eddie Qureshi. I'm the founder and CEO at Rainfall Health. And today, on our hosted program series, we have Dr. Hemant Keny that's going to be joining us. All right. Well, I want to introduce you in here. So, today we have Dr. Hemant Keny joining us, regional clinical leader for surgical quality and safety at Kaiser Permanente Northern California, co leads the senior surgical care program across 21 medical centers, sits on the ACS Geriatric Surgery Verification Leadership Committees, and you've been in Becker's podcast, you've been in the General Surgery News recently, and you're also part of our R.A.I.N advisory clinical subcommittee, which we're very grateful for, helping lead the actual clinical foundations on which a lot of the technology and stuff is built on. So super excited to have you here
Great.
today.
All right. Well, thank you. I'm happy to be here. So it's I've been working for Kaiser for 26 years now, and for 8 years I've been doing the work that you talked about, which is shifting away from clinical care and doing more quality improvement work and improving surgical outcomes, not just one patient at a time, but for the entire region. And so I think we've been successful, and more recently the focus has been on elderly patients because they're a separate high risk category, and they come with a lot of special needs, and we want their outcomes to be just as good as anyone else.
So what got you interested in this?
I was always interested in quality. I've been doing quality improvement work since 2009, looking at our risk-adjusted data and then doing projects to improve that. And then in 2018, I applied for and got the leadership role for the whole region. And since then, we've been working on improving surgical site infections, mortality, readmission, and other complications. And then in about 2019 or 2020, we started implementing the senior surgical care program, which is also known as the Geriatric Surgery Verification Program by the American College of Surgeons. And that was this project that we were part of the initial a group of hospitals that were pilot sites. And then after we saw really great results, we decided to expand that and scale it up to all of our hospitals. And so that's when I came in to lead that work as well.
Well, I have heard that I think Kaiser is one of the most verified system in the country. Is that right?
Yes, we have 14 of our 21 hospitals are officially verified at the highest level, called comprehensive excellence. And when you look at the entire country, we have almost half of the hospitals at this time in the entire country that are verified at that level.
That's amazing. So why take those additional steps? Why go through that additional bar that you want to meet for this area?
Well, we have 4.5 million patients in Northern California, and we have noticed that 7% of them are 75 and older, and 2% of them are 85 and older. So it's a large population that's only increasing over the years. So we realize that they are needing more surgery. They have more complicated situations. They're on more medications. They have more risks. They're more frail. And because of that, we needed a system to manage them better so that their outcomes were better, that we were providing goal concordant care. So patients who wanted surgery were getting it. Patients who didn't want surgery and wanted alternative treatments were getting that as well. And in that end, when you do all of these things, it turns out that you have better outcomes as well afterwards. So that was the driving force behind it.
No, that's amazing. And is this verification program, is this something that's recognized at a national stage, and who's sort of the body that oversees it?
So it's the American College of Surgeons, which is the preeminent national organization for.
Where you hold some leadership roles, right?
Yeah, I'm on the leadership committee for the GSV program, and so there's a whole group of people from around the country, mostly in academics, but other private surgeons and community surgeons like myself. But that they're the ones that came up with the program by reviewing the body of literature that existed at the time, combining it into a large bundle of interventions that would help patients, and then packaging it as a program. And then we were one of the pilot sites for it, And then afterwards, as I said, we decided to expand it to all of the other hospitals because of the benefits that we were seeing for patients and the system.
Wow, that's really amazing. Well, let's take a step into the larger picture right now of what's happening, not just with healthcare, but also these mandatory models that are coming out specifically from CMS, CMMI, which is their innovation group, and there's this really strong push towards quality now actually being a strong pillar of reimbursement as a function of how it leads to outcomes. And I would think a lot of the work that you've done from the quality perspective, from the specific geriatric surgery verification program perspective, would fold very neatly into some of these areas of focus because even though these include mostly orthopedics, cardio, and GI, some of the work that you've done sits sort of on top, right? Just at the quality and outcomes level.
So all surgical patients have the same risks. So whether you're having cardiac surgery, orthopedic surgery, general surgery, vascular surgery, all of those patients are potentially high risk, both from their own medical standpoint, but also in the nature of the operations that they're having. So all of the interventions that we have implemented are applicable to all of those different specialties. On top of the ones you mentioned, we have urology patients, thoracic surgery, spine surgery, neurosurgery patients. All of
Mm-hmm.
those are ones that have been incorporated into our program and reap the benefits of this for their patients as well.
Yeah. So, do you think it makes sense to have these sort of be the requirements, sort of helping the guidelines on best practices as we not only start off with team transforming episode accountability model this year, but also expanding into some of the aspects of age-friendly measures and the composite joint replacement expanded that kicks off next
Yeah.
year. Again, on the mandatory side, would it make sense to have these aspects be included because they're all post-surgical
Yeah.
programs?
So all of them are based on the current literature. So every single intervention that has been recommended as part of these programs has literature to uh, show that it's beneficial. And so what they've done is put all of these successful interventions together into one package. So you know, having it be mandatory, I think, is helpful because when you make it voluntary, it's easy to skip certain difficult aspects of it, and you don't get the full benefit unless you do as much of it as possible. So I do agree with the mandatory nature of it because otherwise it's easy to not do it. It's healthcare systems are it's difficult to change. It's like turning a cruise ship. So that's something that we've known over the years. It's so the more you have that is tied to reimbursement and having better quality outcomes as a part of that, I think is all beneficial.
No, that's amazing. So again, for other folks who don't might not be as immersed in the programs as you are, can you help define like frailty? That's one of the criteria that you focus on, and how it might impact these post-surgical episodes as well as surgeries and the patients, most importantly themselves.
Sure. So frailty is one of what are called geriatric vulnerabilities. So patients have, frailty is a sign of overall aging and weakness. So there are, 80-year-old patients who are running marathons, but there are 80-year-old patients who can barely walk or are bedbound. So you cannot treat those two patients the same. Now, there are other geriatric vulnerabilities like cognitive impairment, mobility issues, nutritional function, and those have to be addressed as well. So, the way that we look at it is that you have to do a geriatric assessment, which measures how patients are objectively for all of those different vulnerabilities. And frailty is one of those measurements, which is independently tied to poorer outcomes. So the more frail a patient is, the worse their outcomes tend to be after major surgery.
Hmm. That it's just interesting how the actual landscape. If you really think about value-based care and its history, it's been a promise coming in for about a quarter of a century, right? For the last 25 years, we've heard these
Yeah.
aspects come out, and now it seems like with these mandatory models and how they're affecting, starting with 750 facilities this year, and then every single acute care hospital next year, it has the ability to have this sort of broad sweeping changes that can come in, and we can set in some of these best practices that you're talking about up front and center. But as people are sort of getting ready for that, how do we think about not just making it a financial lever that um, folks are like health systems are focused on, and not just cost avoidance, but really thinking about more holistically the actual drivers of value, which is going to be the quality, the patient satisfaction, the outcomes, and then costs as a part of it as well, right?
So you have to think of it as improving quality will improve cost and not the other way around. So when you improve quality, you will decrease cost. And part of that is having, these are the components of age-friendly care. So having better goals of care conversations with patients so that the ones who want surgery and are willing to go through the risk end up having surgery. The ones who prefer alternative treatments go in that direction. And then for the ones who want to have surgery, they need to be optimized, and that may take some time. It's before our goal was efficiency, getting patients into surgery as quick as possible. And I think taking a step back and making sure that patients are optimized before surgery is better. And sometimes that takes weeks, sometimes it can take even months. But if you have a patient that's in better shape, if they're nutritionally more sound, if they're able to walk longer distances, if they're off high risk medications, then those patients do better as well. So I think it's, the quality piece of it is tied to cost. And as you improve quality, the cost will be better as well.
Yeah, so that's really the strategic benefit would be by investing in better infrastructure, better practices, you're actually driving towards lower costs and better outcomes overall.
Yes. I mean, you can see just having better outcomes reduces your cost, right? Because there's a cost associated with every infection, every readmission, every other complication has a cost associated with it. So if you prevent those, um, then then you're saving costs there as well. Now there are other costs of benefits to patients where if they choose not to have surgery, then you are also lowering the cost by having them choose alternative means and going down a different pathway that doesn't carry so much risk for the hospital or the hospital system in terms of cost.
That's such a great point because a lot of these in-scope procedures that's coming out from CMS are elective procedures.
Mm-hmm.
So being able to have that conversation and prepare people ahead of time, and then also help them select or opt out, it is a benefit that really aligns incentives from the patient
Mm-hmm.
to the clinician to the provider, and then ultimately the payer as well, which is
Sure.
CMS, right?
Yeah, definitely.
No, amazing. Well, one of the things I think that'd be helpful is even though the team model or these models go post-op, right? 30 days post-op this year, and then we have 90 days with CJRX
Mm-hmm.
next year. A lot of what you're talking about is actually happening in the pre-op side of the
Yeah.
equation. What, like, could you walk us through like a patient journey, where
Sure.
it starts and where it
Yeah,
should go?
absolutely. The patient journey starts when they first get referred to the surgeon, right? So the surgeons typically we want to take ownership of the process, right? Patients having surgery requires surgeons in the mix. So it starts there where with goals of care conversations, right? Deciding what a patient wants with the surgery, what they hope to gain from it, whether that's realistic or not, and what the recovery looks like. So all of those things have to be discussed with between the patient and the surgeon and the family. Then, if the patient is, wants to go ahead with surgery, then it requires this preoperative evaluation, right? And that includes this geriatric assessment, frailty assessment, et cetera. And during that evaluation, if there is anything found that needs optimization, then that should be done preoperatively as well. And then after surgery, the components that help with improved care are doing daily assessments to prevent delirium, having geriatric friendly rooms, making sure that patients get their what's called PSE or things like dentures, their glasses, their hearing aids, so that they're not confused when they come out of surgery. And then after they go through their hospitalization at the time of discharge, they should have another assessment to see what sort of post-operative care they need, whether it's at home, whether it's at a nursing facility, whether it's in rehab. And we have social workers and patient care coordinators who do a lot of that. And all of these things are to help patients recover better at home so that they're less likely to get readmitted and come back in with some sort of complications. So it helps with decreasing length of stay in the hospital as well as decreasing the readmission rate for patients.
So both of those are some of the most expensive parts of, a post-op
Yeah,
episode
absolutely. Every
anyways.
complication, prolongs the stay in the hospital. Each day is expensive. Sometimes patients go to the ICU. That's even more expensive. And then if they go home and they come back, it all starts over with them coming back into the hospital. So yeah, the more that can be avoided, the better it is.
So what do you think is the current level of education and understanding that a lot of the decision makers have right now at the system level about these sort of items?
I think there's, certainly people know that the elderly population is exploding. People know that they're requiring more care. In terms of the nuts and bolts of how to do it, I think is probably less well known. And there are multiple organizations, including the ACS, that are spreading the word. CMS is spreading the word. So I think more of that is coming through, but the local implementation, I think, still is behind. And the more of that we can do, the better.
So how would we advocate for the patient? Like we have a mandate coming down.
Mhm.
There's significant dollars and cents that make it actually there is a penalty element, but I like to focus on the upside, right? Like
Sure.
you can think about it as how do we actually invest in better practices, better clinical workflows, better infrastructure to better serve the patient, right?
Yeah.
And so if you have these new dollars that are becoming available, investing them, but then how do you actually get started in that process?
Well, I think you have to start with the experts. So go with the experts that are there, and then we know what to do. It just takes a long time to implement it. You've probably heard that it takes 17 years in the healthcare system for something to go from being known to being routine, and so we have to speed that time up. And luckily, there are plenty of people doing research and putting together these best practices. It's just a matter of following them. There are multiple surgical societies that put together these recommendations, and there are plenty of geriatric societies that do the same. So the knowledge is there. It's just really a question of how much are systems willing to put in an effort to have the resources there for patients who are considering surgery and going through it.
Yeah, that makes a lot of sense. Well, right now, what do you think with the AI boom? Is that something that we can leverage at this point in time and to make this process more seamless? Because 17 years, yeah, my sense, it sounds shockingly,
Yeah.
bad to anybody not in healthcare, but in healthcare, I think this would be an of course statement, right? Like, yes, I'm not surprised it takes that long in a place where even cutting edge technologies take 2 years to just go through the process to get into the hospital for the very first
Mhm.
time. So, do you think AI is going to change any of this landscape?
Yeah, I think definitely AI is changing everything about what we do in all of our lives, right? That's the new thing. But I think, and certainly see that there are applications. Already, I'm already using a AI scribe when I see patients, so it saves me time on charting on patients. And there are certainly many other AI tools that I think are helpful. So yeah, as AI becomes more the norm, I think that all of us will get used to using it. I think using AI in our clinical practice is very early in its infancy. So that's something that I think will become more the norm over the next few years, I would think.
So, do you think we have the data elements, or do we need to also get better about collecting the data so that we can feed the AI? Because AI is only as good as the data and how we structure it. And
Yeah.
if we don't do it properly on the clinical side, its use cases are going to be limited as well.
Yeah, I think the AI needs to use, what the current literature states and what are the best practices. That needs to be built into it. It needs to have access to patient data to identify who are frail, who are high risk, and then give tailored recommendations to those providers so that we can get real time recommendations for what can be done, what interventions are missing or could be done to improve care. I think there's a tremendous scope for AI in this space. It's just we're not quite there yet. So hopefully soon.
We'll get there.
Yeah.
I'm curious, from our perspective here at Rainfall Health, we take a strong stance on there has to be this strong element of keeping the human in the loop. The clinician needs to be in the driver's seat. The care coordinators, the case managers, the human in the loop elements can be very strong, especially AI can supplement them, but really at the heart of it, it is that human to human interaction that goes a long way. Any thoughts about that?
Yeah, I think again, healthcare is between doctor and patient. That will never change. Well, I hope it never changes. So, but I think that there's a level of trust that patients have in their doctors, and that the doctors are looking out for their best interest, regardless of the technology that we use. One of the things that happens to me is I do robotic surgery. And when I explain that to patients, they invariably think that it's a robot doing the surgery. And, I have to tell them every single time that no, it's not a robot. It's just a machine that looks like a robot that I use to do the surgery. So I'm the one doing the surgery. I'm using this tool. But again, that's a technological advance, which I think is beneficial, but it requires explanation. And I think the AI tools that we use are going to be something similar, both for clinicians as well as for patients.
That, that's exciting. Again, that knowledge gap between what the patient is experiencing as well as what the clinician is sort of used to in some ways, like how that always goes hand in hand. From the patient side of the equation, I'm always curious, like they are so central to everything that we do on the healthcare side, and yet a lot of the times they get put off to the side as well. Do you think there is this element of like personalization and from the technology perspective, as well as like putting them front and center as part of the reimbursement that and the steps that CMS is taking with these mandatory models that might shift how much say and how much presence that we can have around an individual patient to help drive each journey as sort of a personalized one?
Yeah, absolutely. I think patients certainly want personalization. I mean, I think that's something we see all the time. They don't want to be treated like a number or just any other patient. So I think that starts with the conversations between physicians and the patients, but the system also can help with that. I think, patient education can be tailored to this. I think their experience going through the system can be tailored. A lot of patients feel like they don't get enough from the system. They don't hear, it's hard to connect with people and get their questions answered, and every patient's journey is different. So yeah, having tools to help them go through the process on a more personalized basis, I think certainly would be desired by them.
Oh, that's amazing. I do want to go back for a second to one of the things you mentioned. So delirium, we talked about that as one of the vulnerability factors. Why is it so critical for a mandate like team? Like, in your opinion?
So delirium is a very difficult complication to both identify and then to deal with. So patients who are elderly have a high risk of delirium in general, but there are also risk factors for it. So patients have underlying dementia, or they have cognitive impairment of any kind, or they're going through a big operation, they get a lot of anesthetic, they're at high risk for delirium afterwards. So if they get delirium, then their length of stay goes up. It's very distressing for their family because they don't look like the person that they know. Sometimes it's hard to diagnose. There's a very large cost associated with it, and there are long-term changes. So patients may not fully functionally recover from the delirium, that they may always have some degree of cognitive impairment long-term. And so I think from a cost standpoint and a patient standpoint, I think it's a very big complication or problem that needs to be resolved or at least improved, as with any other complication.
Yeah, absolutely. Well, one of the things that I think strikes me is at the top of the conversation, you were mentioning how these are just best practices. They span across surgeries. And now what we're seeing as these big moves that are happening in healthcare, they're not only limited to just a handful of procedures to start, but they're also limited to just a few facilities, and within those, limited to just Medicare right now. Um, does does it make sense for it to go beyond? Should it be going broader to the general geriatric population and across private payers and across all health systems as well?
Yeah, I think ultimately, we have things that are beneficial, interventions that are beneficial. We should be doing them for all patients that would benefit from them. Now, I think the elderly population has more risk than younger, healthier patients. They generally do very well with surgery, without much of an intervention. But yeah, certainly, I think starting with the elderly population for the reasons we spoke about earlier, I think is a good place to begin. But I wouldn't be opposed to having it go to all patients as well. So.
It sounds like it's just be better for everybody involved.
Yeah, absolutely. I mean, if something's better, we should be doing it for everyone.
I couldn't agree more. All right, what have we not covered? Like what should we be thinking about generally?
I think we should be focused on implementation or change management. That is, I think, the most difficult piece, having done this in a large healthcare system, that even things that are known to be beneficial are hard to translate into practice on a daily basis. So I think it's easier to create the technology, but having the technology by itself isn't a guarantee that it will get utilized to its full potential. So I think that not only having the technology, but figuring out how to implement it successfully is the biggest challenge I see in this space.
So what works and what doesn't work in that?
What doesn't work is unfortunately making things mandatory. But I think even though we think that that is the best way of doing it, but we really need to convince people that there are, both patients and clinicians and other providers need to know what the benefits are. And once they see what the benefits are, then they will do it themselves. Once they have, I've hundreds of stories of patients who have come back and told us about their experience and how much better it was than what they were doing before. Some people had, let's say, a knee replacement on one side using our old system, and then now they have their knee replacement on the other side with our new system, and they tell us it's so much better the way we're doing it now than what we were doing before. So when patients and surgeons and other people hear that, then they want to do more of this, right? All of us are looking to have the best outcomes we have. Nobody wants to have more complications or more issues. They want everyone to have surgery, have a smooth recovery, and then go back to their lives as best they can afterwards.
How do you make it easier to disseminate really complex and ever-changing guidelines?
Yeah, it's a challenge. I think most of the time we do it through the surgical societies. Doctors tend to rely on the leaders in their own field more than anybody else, and so these people who have, established their reputations as being knowledgeable and objective, and wanting the best for patients as well as their fellow physicians. I think those are the places where we start from. So most societies have summaries of care that they put through every few years. They update them, and that's what I think what most surgeons and other physicians do when they go to conferences every year. They learn the newest ideas. That's probably the best way to do it. That's why I'm part of the American College of Surgeons, and we do that there.
No, that's amazing. Any other thoughts before we wrap up?
No, I'm glad to hear that finally we're making headway into the healthcare system, right? I mean, I've been doing this for 26 years, and some of the things I'm doing now are the same exact thing that I did 26 years ago. But there are things that have changed over the years. When I started, we weren't using an electronic health record,
Hmm.
and now we are, and that's changed to what we are now. I've just started to use the AI scribe, and that's helping my practice as well. I expect that over the next 10 years, probably in the time that I'm still practicing and beyond, when I'm just a patient, I think that these tools will help us provide better care overall. And that's what I'm looking forward to.
No, that's pretty amazing. And you know what's interesting for for me specifically, in the time that we at Rainfall Health have been working to help empower health systems to work better and serve patients, serve clinicians better. Um, there there's a culture in different systems and how rapidly everybody um, gravitates towards new technologies and new ways to do things. And you know, in your experience, how does that translate? Because everybody wants to do the right thing. Like you said, every single clinician I've ever met, I come from a long line of clinicians myself, and everybody wants to do the right thing. Why does it sometimes take longer in some institutions than it does in others?
I think with change management, you see different categories of implementors. I would say so. There are early adopters. These are the people that buy the new iPhone every year, and then there are people who are resistors, people who are, no matter what you do, they're going to fight it till the end. And then there's a larger group that's in the middle that are open to change, but they want to wait and see, how it progresses. They're not the ones who jump in at the beginning, but if they see something better, they will adopt it. And I think that's the group that we have to focus on, right? The early adopters will take anything and run with it, and those are great to have on board as well. But the largest group is these people in the middle, and those are the ones that you have to convince that there's something that what they're intending on doing is better and more efficient, has better outcomes than what they're currently doing. And once they realize that, then they'll make the switch. But it can take a while for them to accept that.
What would you say to that group right now about the stuff that we've been talking about?
I would say, changes are coming. We clearly see that there are ways of doing things better than what we were doing before. The technology is there to help us, and don't be afraid of it. I think we still need doctors and to manage patients. That's what patients want, and these are just tools to help us do things better.
I couldn't agree more. Well, thank you so much for
Sure.
joining us and sharing your insights.
Great.
We appreciate it.
No, no, thank you very much.